Hello everyone, myself Dr. Anurag Tiwari, and today I am presenting how to examine the hip case. If you are doing MS Orthopedics or Diploma or DNB Orthopedics in your exam, definitely there will be a case on hip examination and you have to do the examination in order to pass. So let us see one by one what are the different examination points you need to understand. I have made a short list of a long case list. If you get any hip case, the possible or probable diagnosis could be either it is tuberculosis of the hip joint, the tubercular arthritis, either it is avascular necrosis, Perthes disease in a child, or non-union, it could be neck of femur or non-union intertrochanteric femur or malunion intertrochanteric femur, septic sequelae of the hip, and the slip capital femoral epiphysis. So this is not the complete list, but however in a majority of cases you will get the diagnosis. You have to make a diagnosis from these. So these are the majority of the diagnosis they fit in. Similarly, we have the short case list. It could be chronic osteomyelitis, non-union, CTV, bony swelling, nerve palsy, cubitus varus, the deformities around the elbow. So this is the complete list. You can have a look and you prepare according to these list your cases for the examination. The common symptoms in a hip case or in a hip disease, the most common is the pain. Usually the patient presents with a pain around the hip and he or she typically says that it is around the anterior aspect or the lateral aspect of the hip and it increases while walking if it is a degenerative type of pain, or it decreases while walking if it is an inflammatory type of pain. Similarly, the patient may present with a swelling or fullness in the Scarpa's triangle. So this is the Scarpa's triangle, very favorite question from the examiner. It is present on the anterior aspect of the hip joint that is bounded by the inguinal ligament superiorly, the medial border of the sartorius muscle laterally, and the medial border of the adductor longus medially. So this is adductor longus, this is sartorius, and this is the inguinal ligament. If anything related to the hip joint, if there is any cold abscess or swelling or any sinus, it will be present in this triangle. That is the significance of this Scarpa's triangle. The last thing, the shortening. The patient may present with shortening because of the destruction of the joint, because of the destruction of the cartilage, because of the dislocation, because of the fracture. The patient may present with the shortening. And in the last, the patient may present with difficulty in walking. The patient may have the difficulty while walking and he or she may use some support, a walking aid, walking stick or a walker, something like that, and that is, we call it as a limp whenever the patient has some difficulty in walking. So you have to describe in your exam that these are the symptoms and what are the presenting complaints. Now I move on to the examination of the hip. There is a particular sequence in which you have to follow so that you don't forget or you don't miss any particular examination finding. So I usually follow from the gait while the patient walks, then examination in a standing position, examination in sitting, squatting, cross leg sitting, finally in the lying down position, the patient in supine position, then on the side, and lastly in the prone position. So this sequence, if you remember, you will not miss any important clinical finding. Similarly, in the finding, whenever you do the examination, you have to follow a particular sequence: look, feel, move, measure, and finally spatial test. So look means inspection. Just remember one thing: whenever you are inspecting, you don't have to touch the patient. You will not touch the patient, you only visualize from a distance. When you palpate, you can touch the patient. The touch is allowed in palpation. So if the examiner is saying that you demonstrate this particular palpatory finding in a patient, then only you can touch the patient. If the examiner is saying that inspect the hip joint, then you cannot touch the patient. You have to only say the finding which are visible. Lastly, the movement, you have to check for the deformity and the range of movement. The range of movement could be flexion extension, the abduction and adduction, and internal rotation and external rotation. Measurement, you have to check for the limb line discrepancy and various other measurements we will see in the video. And lastly, we have the spatial test for the hip examination. Now let us move on to the video. So this is a young male having a problem in the left side of the left hip. He is suffering from, is having pain and deformity on the left side. So before starting the examination, it is very important to have a good exposure. So like as you see in this patient, the good exposure is important. Only cover the private parts and rest all you have to expose. Before starting on going for the examination, it's very essential to have a good marking. So I am marking here, I am palpating, I am marking the anterior superior iliac spine on the right side. So the technique is you palpate along the groin crease or along the inguinal ligament. The first bony landmark you feel is the ASI, that is the anterior superior iliac spine on the iliac bone. So I usually prefer to mark it with a marking pen with a cross and a circle. The same procedure on the left side, I palpate along the groin crease, and the first bony landmark you feel is the ASIS. Just mark it with a cross and a circle, and it should be visible on both the sides, as you can see. Next is the joint line of the knee. You palpate just by the side of the patella on the medial side. The slight depression you can feel, that is the knee joint line. The same on the left side, the femur and the tibia, the femur condyle and the tibia you can feel, you can palpate, roll your finger and you mark this. In the ankle, you mark the medial malleolus, the lower point of the medial malleolus. Somebody has already marked. Just marking this on the right side as well as on the left side. Okay. इस साइड से आ जाएं. हल्का सा पैर को मान लें. So on the right side, I am marking. I am feeling the femur bone from distal to proximal, and where the last bony landmark or the bony prominence I could feel. This is the tip of the greater trochanter. So I have made the greater trochanter, and this is the tip of the greater trochanter. Same procedure on the left side. थोड़ा सा ऐसे हो जाइए. So along the bony femur, along the bony palpation, you just have to feel that there is a tip. So this is the greater trochanter. To confirm this, just keep a hand over here, and when you rotate the ankle, you can feel that the greater trochanter tip is rotating. Okay. So the gait of the patient, you ask the patient to walk in a single straight line. चलिए. So there are various types of gait in the hip examination. चलते रहिए. Just remember the three. One is antalgic gait, Trendelenburg gait, and the short limb gait. चलिए. So this is typical of antalgic gait. The patient is walking, the left side is affected. When the patient is walking, he is keeping the left side minimum time duration in the stance phase. So there are two phases in the gait cycle. One is the stance phase, the other is the swing phase. In the antalgic gait is a painful gait. Whenever there is a pain in the hip, the patient is keeping the limb as low as possible, as minimum time duration during the stance phase. फिर से चल के बताइए. So on the left side, the patient is bearing weight for the minimum duration of time. So that is the classical of antalgic gait, with some component of the Trendelenburg also is visible. Now the next is you examine in the standing position. You have to comment only on the label of ASIS, the attitude of the limb from the front side. So the first thing is label of ASIS. So I am seeing from the front. If you see, इसको ऊपर कर लीजिए बस. Show the close up. You can see that ASIS on the right side is here, on the left side it is here. So the left side, the ASIS is at a lower level. The second, the attitude of the limb, if you can see that the knee is in slight flexion. It is because the ASIS on the left side is at a lower side. So to compensate this lengthening, the apparent lengthening on the left side, the patient is keeping the knee in a flex position, in slightly flex position. इस तरफ घूम जाइए. Then the next is from the side. ऐसे रख लीजिए दोनों हाथ, उसको भी रख लें. From the side, you have only to comment on the lumbar lordosis. Lumbar lordosis is the curvature of the spine in this plane. So you can feel that, you can see that there is a lordosis in the lumbar region. There is anterior convexity. This suggests, or this gives an impression that the patient is having the flexion deformity at the hip. To compensate the flexion deformity, there is a lumbar lordosis. पीछे मुड़ जाइए, सीधा खड़े रहिए बिल्कुल. Last is in the standing position, you have to examine from the back side. So from the back side, you have to see that you can mark, or you can see that the spinous process of the spine. You can see that there is a slight curvature on the left side. This is called as scoliosis, or because of the hip deformity. Since the left side ASIS is at a lower level, in order to compensate this, the pelvis is tilted like this. So to compensate this, the spine has been deviated towards the convexity towards the left. I hope this is clear. So this is not a structural scoliosis. This is because of the deformity in the hip. To compensate the deformity, there is a scoliosis in the spine. ठीक है, सीधे हो जाइए. एक चेयर दे दें, इस पर बैठ जाएं. Next is the examination in the sitting position. In the sitting position, you only have to comment that whether the ASIS level has been changed or not. So you can see that the ASIS is still in the lower side in this side, and on the right side it is at a higher level. खड़े हो जाइए. अभी नीचे बैठ जाएं, ओकड़ू बैठते हैं जैसे, पूरा नहीं टिका पाते एड़ी, है ना. ठीक है. So this is the examination in a squatting position. As you can see, the patient is not able to put the heel on the ground. That means the hip flexion is less. For squatting, you need at least 120 to 130 degree of flexion, or maybe more of a flexion. आलती पालती लगा के बैठ जाएं. Next is you ask the patient to sit cross-leg. So in cross-leg, he is having some problem, not able to sit cross-leg. That means you need a good flexion, abduction as well as external rotation in order to sit a good sitting on the cross-leg position. So that means the external rotation is also somewhat restricted. Examination is in a lying down position. In the lying down position, you have to check that the patient is comfortable and the lower limbs are parallel. And the second most important thing, there should be no mattress. There should be a hard couch. The couch should be hard. This mattress should not be used. So in the supine position, you have to make again a sequence so that you don't forget to miss anything. So you go from head to toe. So from head to toe, you have to check for the spine curvature, then in the hip region, knee, and then lastly is the ankle. So we'll go from one by one. So first is the inspection in lying position, supine. So inspection, you always remember that you don't have to touch the patient, you only see the patient. So in this position, you have to check there is lumbar lordosis or not. So the best way is you just see through the, focus करें. If you see clearly that the light is passing through the back, between the back and the couch. So this is the impression, or this is the right way to check, to inspect the lumbar lordosis. This means there is exaggerated lumbar lordosis. Next is you have to examine the hip area. So from the inspection, you have to comment on the ASIS level. As you can see, यहाँ से focus करें. Right is at a higher level, like the affected side is where. So affected side is left. So you always have to say the left side ASIS is at a lower level as compared to right. You can clearly see that this is the ASIS, this is the ASIS on the right side. So ASIS on the left side is at a lower level. There is a scar mark over the healed scar mark over the Scarpa's triangle or over the anterior aspect of the hip joint on the left side. You have to say healed by primary intention or secondary intention. You will comment this. Is there any swelling? So I could not see any swelling. So there is no swelling. There is no sinus over the hip region or over the groin area. Next is the attitude of the limb. और ऊपर हो जाइए.
The attitude of the limb on the left side is slight inflection, the knee flexion, and a slight external rotation. As you can see from this side, जैसे दिखाएं. The feet. The normal side is this right side, whereas on the left side it is at a more external rotated. So the attitude of the limb, the knee is in flexion and it is in external rotation as compared to the right side. And the last thing is you have to check the label of the medial malleolus. So if you can see the label of medial malleolus on the right side is here, on the left side is here. More or less it is same, or maybe on the left side it is at a slightly lower level. So the medial malleolus is at a distal level on the left side as compared to right side. So this suggests that there is a lengthening on the left side. More likely it is apparent lengthening. So we have covered from the proximal to distal, from head to toe, the lumbar lordosis, the ASIS level, scar, sinus, swelling, attitude, and lastly the level of the medial malleolus. Next is we go for the palpation. Now when you go for palpation, you can now touch the patient. So always before moving on palpation, the first thing is the temperature. Because once you do other examination, the patient skin may become warm. And the temperature, the best way is with the back of the hand, because this skin is more sensitive for the temperature. So on the right side, on the left side, I could feel that there is no local rise of temperature. The next is you check for the tenderness. You check for the tenderness in the hip region, you check for the tenderness. The landmark is you palpate the pubic tubercle, you palpate the ASIS, the midpoint of the mid-inguinal point. So from the pubic symphysis to ASIS, you make a line and you take the midpoint of this approximately 2.5 centimeter below and lateral to this point. You have to palpate the head of the femur and you press. And you have to see on the patient's face, the patient is having pain. So on the left side there is tenderness, on the right side there is no tenderness. So there is anterior, or you can say directly the hip joint tenderness on the left side is present. The next tenderness is bitrochanteric. You palpate both the trochanter and you press, as in you are compressing both the hip. So if there is a tenderness, this is bitrochanteric tenderness, is positive or negative. Next is you have to comment on the scar, that whether the scar has been healed, the size of the scar, approximately 3 to 4 centimeter, whereas in palpation you can directly dimension, you can check, you can measure it with a measuring tape. This is approximately 4 centimeter in size, longitudinal over the anterior aspect of the hip. There is no discharge from the scar and it has well healed. After tenderness, temperature, then you again check for the inspectory findings. You confirm that there is lumbar lordosis. The best way to check is with the hand. You palpate the spine. There is a gap between the couch and the spine. Whether you do like this in the supinated hand or a pronated hand, this makes no difference. But some examiners, they do ask that why do you do in a supinated position or in forearm in pronation position. So I don't know the reason. Whatever way you can do. So if the hand is able, you are able to insinuate the hand between the spine and the couch, that means there is exaggerated lumbar lordosis. So this is the palpation technique to check for the lumbar lordosis. This means that there is a flexion deformity in the hip. Next, if there is any swelling or if there is any sinus, you have to comment upon that. And in the last, you just check for the medial malleolus. The medial malleolus is here, medial malleolus is here. Yes, there is lengthening on the left side, the medial malleolus, by checking the level of the medial malleolus. So this completes the palpation in the supine position. All the points we have covered. One thing is left, that is the trochanter. So you have to palpate the trochanter, the trochanteric tip. You keep the middle finger on the trochanter tip, the thumb over the ASIS, and the index finger is line passing through the vertical line passing through the ASIS and is the one line joining through the along the shaft of the femur. So the point where it intersects, this point should be the over the index finger. You keep the hand on the right side as well as the left side. Again on the right side, the middle finger is on the GT tip, the thumb is over the ASIS, and the index finger is in between these two lines. So when you see this, you will compare the distance between the index and the middle finger on the right side and on the left side. You can see that the distance between the middle and index on the left side is less as compared to the right side. So this means there is proximal migration of the trochanter. And for trochanteric tenderness, you have to again palpate the femur and you palpate the trochanter in order to check whether there is any thickening or broadening of the trochanter and how is the surface. So the surface appears to be smooth and there is no broadening and thickening of the trochanter as I can compare on both the sides. So this is the way how you compare the thickening and broadening of the trochanter. This is the way how you feel for the surface of the trochanter, and the proximal migration is given by the digital disc technique, the 3-digit technique. So this completes the entire palpation from head to toe. After palpation, we check for the deformity. So there are 3 plane deformities. One is the flexion deformity, the other is coronal plane deformity, abduction or adduction, and the third is rotational deformity, internal rotation or external rotation. The first is, we will go with the flexion deformity. How to check for the flexion deformity? You have to check that whether there is lumbar lordosis. Yes, we have checked that there is exaggerated lumbar lordosis. This test is known as Thomas test. This is very important for the exam going. Each and every examiner will definitely ask you this. So I will go slow. You have to check for the lumbar lordosis. I have kept my hand, the left hand over just beneath the spine. You touch the normal leg. I repeat, you flex the normal limb. So when you flex the normal hip, इसको मोड़ लीजिए और मोड़ते जाइए. To the level when I could feel that now the spine is almost touching the couch. You can see that the lordosis has been obliterated. To this point, you ask the patient to hold this in the same position. With the other hand, you just do this extension of the knee. So now this angle, which this limb, इसको पकड़ के रखिएगा. Now this angle, the affected hip or the affected thigh makes with the couch is the angle of flexion deformity. Give me the goniometer. So again the examiner will ask you that how will you measure this angle? Whether it is the bony angle, whether it is the anterior surface, whether it is the posterior surface. So answer here is the posterior surface of the thigh. So you have to check, you have to measure the angle between this couch surface and the posterior aspect of the thigh. So this angle will give you the idea, the angle of flexion deformity. How much is the flexion deformity on the left side? About the junction where the thigh meets the proximal area meets the couch. You keep this limb of goniometer parallel to the couch and this limb parallel to this posterior aspect of the thigh. So this angle on the goniometer, it makes an angle of about 40 degree. So around 40 or 45 degree, whatever is the value. This gives you an idea about the flexion deformity. ठीक है, ढीला छोड़ दीजिए. So this is the Thomas test. The way you do, you always have to check for the lumbar lordosis. Keep the hand over between the spine and the couch. You flex the normal hip. Most of the students, they make the mistake that they flex the affected hip. So that is wrong. You don't have to touch the affected hip. It is always the normal hip. You flex the normal hip to the point when it obliterates the lumbar lordosis. The angle which it makes the affected hip with the couch is the angle of flexion deformity. So this much is the flexion deformity. ढीला छोड़ दीजिए बिल्कुल.
Let's understand what is Thomas test through this animation video. If there is a flexion deformity of the hip joint, the patient will have the hip in flexion, anterior and the posterior side. So if you see carefully, there is a deformity of around 30 degree or 40 degree, whatever. There is a angle from the midline, the hip joint or the limb is making at an angle of 30 degree. Now this foot or this limb cannot be put here or cannot be corrected to its normal location. That's why there is deformity. Whereas we can further flex this limb to more than 30 degree. So we can move this but we cannot move the limb in opposite direction. So that is the basic thing about the deformity. If there is a flexion deformity, that means you can further flex the hip joint, but you cannot extend the hip joint. So that is the major or the basic concept about the deformity. Now let us understand, if the patient is not able to extend and he has to stand on these limbs, the patient will not be standing like this, as you can see from this animated this structure. So in order to stand, what the patient will do, patient will flex the trunk. In order to stand, the patient will keep the limbs almost perpendicular to the ground, but doing so, the patient will have to flex the trunk like this. As you can see that there is a deformity, the patient cannot change this angulation. So this angulation will be there, whatever position the patient may stand. So patient will stand like this, but again now the face is directed towards the inferior aspect. So while the patient wants to walk, the patient cannot walk in this position. So what he will do, he will compensate this by increasing the curvature of the spine. So this increase in the curvature of the spine, in order to stand erect and to walk in a straight line, this compensation is by increase in the lumbar lordosis. This is lumbar lordosis. So the lumbar spine, they undergo compensation, they undergo a great curvature in order to compensate for the flexion deformity of the hip. So in this position, now the patient can walk. Now the patient can lie straight in a supine position with increase in the lumbar lordosis. Now how will you reveal that there is flexion deformity or not? So you ask the patient to lie supine. In a supine position, you will see that there is a exaggerated lumbar lordosis. Now to reveal this, you have to obliterate the lumbar lordosis. Now in order to obliterate the lumbar lordosis, you have to flex the hip. Now you will flex the normal hip. So let us say now this is normal hip and this is affected hip, affected limb. So when you flex the normal hip to a particular degree, the lordosis becomes obliterated. At this point, you have to measure the angle between the couch and the posterior aspect of the thigh. So this angle will give you, so this is the angle which gives you the deformity, that is the flexion deformity, also known as fixed flexion deformity of the hip. So this is the pathomechanics behind the Thomas test. In order to compensate, the patient do the increase in the lumbar lordosis. In order to reveal the deformity, you will have to obliterate the lumbar lordosis. Once the lordosis is obliterated, the angle which the hip makes with the couch is the angle of flexion deformity.
Next is you check for the coronal plane deformity. Now for coronal plane deformity, the coronal plane is abduction or adduction, abduction or adduction deformity. So there are two methods. One method is Perkins method and the other method is Kothari parallelogram method. I will tell you the Perkins method first. You have to check the ASIS level. As you can see, the ASIS on the right side is at a higher level, on the left side is at a lower level. Whenever ASIS is at a lower level, it is abduction deformity. Which deformity? Abduction, abduction deformity. If the ASIS on the affected side is at a higher level, it is adduction, adduction deformity. So to check or to confirm, when you do the abduction on the affected side, the ASIS level, they become collinear. Now you can appreciate that the ASIS are now in the same line. They are at a same level. The point where they become in the same line, the angle with the midline this limb makes is the angle of abduction deformity. So this will be around maybe 30 to 40 degrees, whatever is, you can check with the goniometer. You keep the goniometer over this point and you check with the inner aspect of the thigh and the center midline. If it is the ASIS is at a higher level, then it is adduction deformity. In such case, to square the pelvis, you will adduct the affected limb. If you will move the normal limb, the ASIS level will not change because there is no deformity. Okay. So for coronal plane deformity, you have to move the affected side. For flexion deformity, you have to move the normal hip. Okay. Then there is a Kothari parallelogram method. Fine. Now Kothari parallelogram method is given by Dr. Kothari. He draw the line, that is the midline, longitudinal. Then a line drawn from the ASIS, that is perpendicular to this, and another line drawn from this ASIS which is perpendicular to this, and then you connect both the ASIS. So this angle which is made is the amount of abduction or adduction deformity which is present in the hip. So this is another method for detecting the abduction or the adduction deformity, but in this case again this angle you measure is abduction or adduction. This is guided whether the ASIS is at a lower level or at a higher level. Again remember, this Kothari parallelogram you draw in a unsquared pelvis, that is unsquared means when the limbs are parallel, the ASIS is at a different level. For Perkins method, you have to square the pelvis. Square means the ASIS lie at a same level. So for squaring, you move the limb to the desired amount of deformity, to the desired amount when the ASIS become parallel. So this is squaring of pelvis when the ASIS lie at a same level. This is unsquaring or the limbs are parallel in this case. Okay.
In the same way, let us understand that what is abduction deformity. Let us understand through this animation video that how the abduction deformity is there in a patient, how he compensates. So abduction deformity means that the hip is abducted to a particular degree and the patient cannot bring the limb back to normal. So this movement is not possible. That means adduction is not possible, whereas further abduction the patient can do. So this is the basic concept of the abduction deformity. Now since there is a deformity, we check the deformity through this. Now this is approximately, let's say, 20 degree of abduction deformity. Now if the patient wants to walk or patient wants to stand, the patient will not stand like this with the limbs lying far apart. So what he will do, he will move the opposite limb. And when the patient moves the opposite limb, there is no tilting of pelvis because there is no deformity on this side. Since there is no deformity, the patient can move the limb so that both the limbs are now parallel. So as you can see, now the patient has made both the limbs in a parallel position. If the patient wants to stand, the patient again cannot stand in this position. What he will do, he will compensate by tilting the pelvis. So when the patient tilts the pelvis, keeping the lower limbs parallel, so this will be the final picture. In this position, the patient can lie supine, the patient can stand. In this case, now you see carefully, this side was affected, there was abduction deformity, and ASIS is now at a lower level as compared to opposite side. So if you draw the two lines, the horizontal lines through the ASIS, there is lowering of ASIS on affected side. And if you see carefully, now this limb is of this length, whereas this limb is now has been increased by this amount. So this is apparent lengthening. This is not true lengthening, it is because of this tilting of the pelvis. The pelvis get tilt, so the lower limb appears to be longer in size. So this is known as apparent lengthening. So just remember, in abduction deformity, the ASIS is at a lower level and there is apparent lengthening. Clear these 2 points? So this is how we describe the abduction deformity. In order to reveal the deformity, what you have to do, you have to move the affected side in abduction. So when you move the affected limb in abduction, the pelvis will again corrected. The pelvis will again get squared. That is, the ASIS will bring to the normal location or the same location, same level. So the point where the ASIS becomes at a same level, the angle which the limb makes with the midline is the angle of abduction deformity. In the same way, let's understand what is adduction deformity. Adduction deformity means the limb is lying in an adduction position. The patient can further adduct, but patient cannot abduct. If the patient is able to abduct, there will be no deformity. Patient जो है वो normal अपना limb ले आएगा normal location पे. So since there is adduction deformity, the patient cannot abduct. Now how the patient will stand in this position? The patient will move the opposite hip. So the patient will move the opposite hip so that the two limbs now become parallel. In this position, now the patient moves the two limbs to make the limbs parallel. In order to lie supine or in order to stand erect, the patient has to tilt the pelvis. So the patient will move the pelvis like this. Now if you see, this is the ASIS on this side and ASIS on this side. The affected side, the ASIS now moves higher. So this higher means ASIS is at a higher level in adduction deformity, and if you see carefully, this limbs is now appearing apparent short. So there is apparent shortening. So just remember these things. In adduction, adduction deformity, ASIS is at a higher level and there is apparent shortening. Whereas in case of abduction deformity, ASIS was at a lower level and there was apparent lengthening. So if you understand these basic concepts, there will be no confusion in abduction, adduction or flexion deformity. So this is the basic. In hip examination, examiner will definitely like to ask you about the abduction, adduction and the flexion deformity. So just remember this, you will never forget.
The last one is the rotational deformity. For rotational deformity, there is no compensation. It gets revealed on its own. So if you feel here, you can see that the patella is facing outward by about 10 to 15 degree. So from the midline, the patella is facing almost 10 to 15 degree from this position. एक और pen दे दें. So this is the vertical line and this is the patella facing. So this angle which is made between these two is the rough idea giving that amount of external rotation. If the patella is facing inward, it will be internal rotation deformity. If it is facing outward, it is external rotation deformity. If the deformity is present, that means the movement in the plane of deformity will not be present. Sorry, if the deformity is present, if the external rotation deformity is present, the external rotation will be present, but internal rotation will not be present. Correct? So you can check by this way that whether there is rotational deformity or not. In this case, it is almost fixed in the 10 to 15 degree of external rotation, because when I am moving internally or externally, the pelvis is moving. Can you see? So it is almost fixed in 15 degree, let's say 15 degree of external rotation deformity. So this is a fixed deformity. So once we have covered the deformity, now the next is the movements. Flexion, abduction, adduction and the rotation. Again the same movements, the same plane. So first we will do the flexion. For flexion you have to first reveal the deformity. So again the Thomas test, you just have to obliterate the lumbar lordosis. इसको खींच लीजिए. And you ask the patient to hold. Now lumbar lordosis is obliterated. This much amount is the deformity present. From this level you have to check the range of motion, that is from 40 degree of flexion, and again you have to keep one hand over the pelvis or ASIS so that you can check that whether the pelvis is moving or not. So I can see that with a slight movement also the pelvis is moving. That means there is only a jog of movement present in the flexion. Someone would say that I can move it up to here, but this is not the true movement of the hip. This is the pelvis is moving. So the true movement is when the pelvis is not moving. So from the 40 degree deformity, it is only a slight jog of movement. You say only 5 to 10 degree, 5 to 10 degree of movement is only present, or you can just say to the examiner that jog of movements is present. After flexion, it is the extension. So if there is a flexion deformity, the extension will not be there. So you don't have to check for the extension. If there is a flexion deformity, the extension will not be there. So just a rule, if there is a X deformity, the movement X will be possible, but the movement opposite to X will not be possible. So if there is a abduction deformity, abduction will be possible, adduction will not be present. So in the same way, the extension will not be there in this case. Now the next is to check for the abduction deformity. Before going on to this, you always have to check the normal side also. The flexion from 0 degree to, मोड़ लीजिए, almost up to 120 or 130 degree of movement is present. which is painless. Next is abduction or adduction movement. So to check before going on, we have to reveal the abduction deformity. So for this, you have to square the pelvis. So this much is the amount of abduction deformity. The ASIS are now at the same level. From this point, you have to again move further abduction. So again the same, the pelvis is moving. You can see. So there is only a hardly any movement present. So it is fixed in almost 40 degree of abduction deformity. And again the same thing, the adduction will not be possible. So there is no adduction possible because there is abduction deformity present. And the last is external rotation deformity. Again we have already checked, the pelvis is moving. So in this case the hip is flexed in 40 degree of flexion, 40 degree of abduction and 15 degree of external rotation deformity with no movement possible in the hip joint. Clear? And whenever you say for the range of movement, you have to say that the range of movement is painful or painless and whether any spasm present or not. So this gives a clue to the examiner that whether the patient is having a severe painful disease or it is a painless disease. Okay. After movements, we go for the measurements. Did I state? So measurements is you have to check the length. There are two types of length. One is apparent length and the other is true length. The apparent length is what appears to you. Apparent means apparent. सीधा लेट जाइए बिल्कुल. So apparent length is जैसा दिख रहा है. So you ask the patient to lie supine with lower limbs parallel and you take a midline fixed point above the hip. Usually standard is to take the ZP sternum. On the normal side, you just have to measure from the ZP sternum up to the medial malleolus. It is almost 116 centimeter. On the affected side, if it is 117 centimeter. Can you see? So you have to comment that there is 1 centimeter of apparent lengthening on the left side. Don't comment that this is 116, this is 117. The examiner doesn't know mathematics. So always say, make it easier for him. This side is 1 centimeter length and this is apparent length because we have measured from the fixed point, that is the ZP sternum to medial malleolus. Now the second is true length. For true length, just remember two things. One is for true length, you have to first square the pelvis. So to make it square the pelvis, this is the ASIS is at the same level. And second is the normal limb should be in the identical position of the affected side. The affected side is in 40 degree of abduction. So you will keep this also in 40 degree of abduction with some flexion over here. So these 2 points are very important when you measure the true length. One is squaring the pelvis and second is you have to keep the normal side in the identical position or mirror position of the affected side. And again you have to check the ASIS to medial malleolus. This is coming almost 88 centimeter. And on this side, the affected side, it is 85.5 centimeter. Let's say 85 centimeter. So there is 3 centimeter of shortening. 3 centimeter of true shortening and 1 centimeter of apparent lengthening. Clear? So there is 1 centimeter of apparent length with 3 centimeter of true shortening on the left side. After this, you have to draw the Bryan's triangle. We have already drawn by the 3-digit method. Pen. One is the tip of the greater trochanter and the ASIS, that is anterior superior iliac spine. So first you connect these 2 points. Make a horizontal line along the shaft of the femur and a vertical which is drawn from the ASIS. So the point where these 2 lines intersect is the third point. So you get one is the GT, the second is the ASIS, and the third point you need one line you draw along the shaft of the femur and another line vertical from the ASIS. So now this triangle is being formed. This is known as Brine's triangle, and this is the base of the Brine's triangle. This line is the base of the Brine's triangle. Let's say B. So the importance of Brine's triangle is mainly in the base of the Brine's triangle. You have to measure this length. If this length is more, that means there is lengthening. If this length is less, there will be shortening. So this is approximately 6 centimeter. So the base on the right side on the normal side is 6 centimeter. The same way we will draw on the affected side. This is the ASIS, 2 points we already have. You join these 2 points and again along the shaft of the femur or a horizontal line you can draw, and a vertical line through the, this is the third point. So when you measure the base of this triangle, this is almost 4 centimeter. So there is 2 centimeter of shortening on the left side. So Brine's triangle show you the supratrochanteric shortening because this is superior to the trochanter. Whatever shortening is there, it is superior to the trochanter, and this is an idea of true shortening. This is not apparent shortening, this is true shortening. So Brine's triangle is a measurement of a true shortening or true length, and apparent length is because of the abduction deformity. After this, you have to draw the Chinese parallelogram and shoemaker's line. So I will draw the shoemaker's line. The shoemaker's line is from the greater trochanter to ASIS, and you have to extend this further. On the left side, this line, you have to extend it further. So if you see carefully that the two lines, they intersect below the umbilicus and on the right side. So this means that the left side is proximally migrated. The greater trochanter on the left side is proximally migrated. That's why this line is intersecting just distal to the umbilicus and towards the normal side. They are intersecting. So this again confirms that there is some shortening on the left side. After deformity, after movements, after measurements, now the next step is the spatial test. So for a spatial test, we have the 3T Trendelenburg test or Trendelenburg sign, telescopy, and passive SLR, and Thomas test. Thomas test is also included. So first I will do the active SLR. Sorry, active SLR is included in the hip examination. ये वाला पैर उठा लीजिए ऊपर बिना घुटना मोड़े, ऐसे सीधा. So the patient is able to do active SLR on the normal side. ढीला छोड़ दीजिए. इसको उठा लीजिए सीधा बिना हाथ लगाए. इसको छोड़ दीजिए, घुटना सीधा रखें, ऊपर उठा लें. So the patient is able to do active SLR on the left side also. So this proves that there is no discontinuity, there is no fracture, there is no dislocation grossly. The patient is able to actively elevate the limb. Next is Thomas test. We have already done the Thomas test. And last is the telescopy. First, on the normal side, you flex the hip to almost 90 degree. You keep one hand, the thumb over the ASIS and the 4 fingers of the left hand over the trochanter in 90 degree position, and then with the other hand you give a push and pull force in order to check whether the trochanter over the fingers is moving or not. So in a well reduced joint, you will not be able to see any movement, or you will not be able to feel any movement of the trochanter with your fingers. If the telescopy test is positive, you will feel that there is a gross movement which is appreciable with your finger. In this case, you will not be able to do telescopy because the patient is not having the hip flexion of 90 degree. But still, in order to do or in order to complete the examination, in 40 degree of flexion, you can still do the thumb over the ASIS, the fingers over the greater trochanter, and you give the push and pull. There is no movement. So telescopy in 40 degree position is negative. You can comment. Rather than saying that telescopy is not possible because the patient's hip is not able to flex to 90 degree, it is better that you have done this telescopy in 40 degree position. And comparable with the opposite side in 40 degree position, there is no telescopy. So you can better earn your marks. Last one is Trendelenburg sign. Before going into the Trendelenburg sign, I will complete in the prone position. Lateral position first. ऐसे करवट ले लीजिए, इस तरफ. So in lateral position, you only have to check आराम से, बस ऐसे ही रहिए. You only have to draw one line, that is Nielsen's line. For Nielsen's line, you have to make the affected hip on the affected side should be up. You have to mark ASIS and the ischial tuberosity, and you have to draw a line passing through the ASIS to ischial tuberosity. So I can feel that the ischial tuberosity is here, ASIS is over here, and if I have to draw a line, and this line should be drawn again in 90 degree of flexion. But again the problem is, in this case the patient is not able to flex the hip to 90 degree. So in this case it will not give a true measurement. But just to complete the examination, you can still draw in 40 degree of position. So this is the ischial tuberosity to ASI. Ideally, if there is a shortening, the trochanter should cross this line or should proximally migrated through this line. But in this case, we are not getting this. The probable reason is because the patient's hip is not able to, we are not able to flex to 90 degree. So this is giving a wrong impression for the Nielsen's line. So you can comment well that the Nielsen's line is unreliable in this case because we are not able to flex the patient's hip to 90 degree. उल्टा लेट जाइए, उल्टा पूरा उल्टा हो जाइए. In prone position, you have to comment on the wasting, the gluteal muscle wasting if there is any. We cannot see in this case. And the second is palpation. You have to palpate the gluteal region in order to check for the any dislocation. If you can feel with the rotation, if there is any femoral head or bony deformity, bony prominence in the gluteal side which is rotating with the femur, that means it is suggestive of posterior hip dislocation. So there is no wasting, there is no dislocation. So this is the Trendelenburg sign, the Trendelenburg test or sign, whatever you can say. The Trendelenburg sign is to test the abductor mechanism of the hip. First you ask the patient to stand on the normal side. इस पैर पे खड़े हो जाएं, इस पैर को उठा लें. And the examiner or the candidate should be in the line of the hip region. You have to check the movement of the gluteal crease. इधर से दिखाएं एक कैमरा. When the patient is standing on the right side, the left side pelvis is moving up. Whereas when the patient is standing on the left side, इस पे खड़े हों, this side pelvis is not moving up. The patient's body is turning to the left side.
Let's understand what is Trendelenburg sign through this animation video. Trendelenburg sign is actually depicting any problem in the abductor mechanism. Abductor mechanism of hip is very important because this helps in the abduction. So first you understand what is the abductor mechanism, then only you can understand what is Trendelenburg sign. So abductor mechanism, it consists of the hip joint, that is the socket, the head of the femur, the neck of the femur, the intertrochanteric area, abductor muscles, that is the gluteus medius mainly, gluteus medius, minimus and tensor fasciae lata. These are the three abductors, but however the chiefly it is the gluteus medius and the nerve supply of this gluteus medius, that is superior gluteal nerve. So these are the important components of abductor mechanism. So if any particular disease that is affecting the hip joint, if it is affecting the neck, if it is affecting the intertrochanteric region of the hip joint, if it is affecting the muscle is gluteus medius or minimus or other abductor, or if it is affecting the nerve, that is superior gluteal nerve. In any of these five conditions, there will be the abductor mechanism will be affected and Trendelenburg sign will be positive. Now let's understand what is the pathophysiology of Trendelenburg sign. What is this abductor mechanism? So when the patient bears if I am considering that this side is also normal and this side is also normal, let's focus on this side. If this side is normal, when the patient bears the weight on this side, when the patient bears the weight on this side on the ground, the abductor muscle will contract and will cause this pelvis to move towards this side in order to lift the opposite pelvis up, so that the patient can walk easily. He or she may get the ground clearance for this side of the limb. I repeat, whenever the patient bear weight on the normal side, on any one side, there is contraction of the abductor muscles. As a result, the pelvis tilts towards the same side, so that the opposite pelvis moves up and the patient will get a good ground clearance. So let's see through this animation video. So this side is normal. When the patient bears weight on this side, the pelvis moves, the opposite side, the pelvis moves upwards. So this is clear. In order to walk, in order to get a ground clearance for this limb, the patient, this is a compensatory, this is a mechanism, a good mechanism, a physiological response of the pelvis. And this is because the hip is functioning, the neck is good, the intertrochanteric region is good, the muscles are good condition, and the nerve supply is good. If any of this condition is affected, if any of these parameters they are damaged, there will be problem in the trendylomic sign. There will be problem in this abductor mechanism. Now let's see what will happen if if any of this component is abnormal. So when the patient bears weight on this side, that is affected side, this side is now affected, there is some problem in the abductor mechanism, the pelvis will not getting lifted from the opposite side, instead it drops down because of gravity. So when the patient bears weight on the affected side, because there is some problem in the abductor mechanism, the muscle is not getting contracted or the hip joint is not taking the load, the opposite pelvis moves down because of gravity. This is Trendelenburg sign positivity. So just remember one thing, when the patient bears weight on the normal side, opposite side moves up, and when the patient bears weight on the affected side, that is the damaged side, that is the diseased hip, the opposite side, it moves down or it may remain at the same level. Usually it is shifted down because of the gravity, or it may remain same, it doesn't get elevated. So just remember this formula and your Trendelenburg sign is all over.
Always you have to check whether there is any spine tenderness, SI joint, the test for SI joint are normal, the opposite hip is normal, and the ipsilateral knee is normal, and the distal neurovascular status is normal. पैर चलाइए, उंगली चलाएं. So the distal pulses are palpable, the movements are good. So this completes the entire examination. You have to go in a sequence: gait, standing position, sitting, followed by supine position, inspection, palpation, deformity, movements, measurements, and spatial test. So this completes the entire hip examination. To summarize, in this case, the patient is having symptoms in the left side. There is flexion deformity, abduction deformity of 40 degree and external rotation deformity of 15 degree. Almost they are fixed. The deformities, all the three are fixed with slight jog of movements. There is apparent lengthening of 1 centimeter and true shortening of around 3 centimeter with absent telescopy with tenderness positive, and Trendelenburg sign is positive. So these are the all positive and negative findings in this case. Okay, thank you.
Thank you so much. For any queries, you may contact at WhatsApp, Facebook or the YouTube channel. Thank you so much.